So we'll move on to the next speaker. Today, the college lecture will be done by Dr. Danushka Karunaratne. Dr. Karunaratne qualified, graduated from University of Peradeniya, and he was a specialty registrar in rheumatology in Eastbourne District General Hospital. Currently, he is consultant in rheumatology and rehabilitation, at Teaching Hospital, Kurunegala. So he'll be talking about clinical application of the autoantibodies in idiopathic inflammatory myopathies. To you, Danushka.
Thank you very much, sir, for your kind words of introduction. And I would like to take this opportunity to thank both colleges, Ceylon College of Physicians and our own college, College of Specialists in Rheumatology and Rehabilitation, for giving me this great opportunity. And today's my talk will be on, let me minimize this, okay. The talk will be on the clinical applications of the autoantibodies in idiopathic inflammatory myopathies. Yeah, this is going to be the outline of our talk today. So here I'll be talking about the basic points and the classifications of the idiopathic inflammatory myopathies. And then the theme of this talk will be the myositis antibodies and its relevant clinical syndromes. And I would like to share one of my personal experience here in Sri Lanka with regard to these antibodies. And finally, the conclusion. Talking about any specific autoantibodies seen in autoimmune connective tissue disorders, they've been always useful clinical biomarkers to make a diagnosis, and they've been always associated with a particular disease and a clinical manifestations. With regard to immune-mediated myositis, classically the dermatomyositis specific autoantibodies such as anti-Jo1 and anti-MI2 have been in the clinical picture for more than 3 decades, since 1970s. However, in recent years, particularly since 2005, several novel antibodies, which are clinically important autoantibodies, defining the subsets of idiopathic inflammatory myositis, have been identified, and that has revolutionized and changed our insight and way of understanding of this disease, as well as its management. Talking briefly about the idiopathic inflammatory myopathies, which is the novel term since 2018 used for the our well-known terminology of inflammatory myositis. And these are autoimmune diseases affecting both adults and children, characterized by the muscle inflammation leading to proximal muscle weakness. And these clinical entities can often be associated with other systemic involvement, for instance, the cutaneous manifestations as you see in dermatomyositis, and lung involvement in the form of interstitial lung disease, and rarely that could also be associated with cancers. We'll take a brief look at this flow chart, which show us the evolution of idiopathic inflammatory myositis. And it was in 19th century, in 1887, the disease entity of myositis was first described. And a few years later, they've identified a clinical entity where myositis is associated with cutaneous manifestations, classically described in our textbooks as Gottron-Papule-Scholl signs, and then came the entity of dermatomyositis into the classification picture. And in 1978, based on the histology, the inclusion body myositis was also added several decades later into the classification, although it's an ongoing debate whether inclusion body myositis is inflammatory in nature or not. And in 1991, once again, the polymyositis, the patient under the cohort of umbrella term of polymyositis, some of them showed a very rapidly progressive disease, which is characterized by severe myalgia and histological features suggestive of myonecrosis or muscle necrosis, which was then identified as immune-mediated necrotizing myositis. And the current classification since 2018, when actually this new name of idiopathic inflammatory myositis was also suggested, has 5 subcategories: the dermatomyositis, overlap myositis, where myositis is an overlap phenomena with other autoimmune connective tissue disorders such as scleroderma, and immune-mediated necrotizing myopathy, inclusion body myositis, and polymyositis. And talking about the myositis antibody, which is our theme today, they are identified in more than 60% of the patients with inflammatory myopathies. These are the antibodies directed towards ubiquitously expressed intracellular complexes which involve in protein synthesis. And there are always important biomarkers that helps us to make a diagnosis and classify our patient into more homogeneous group, or which we call syndromes. In addition, they helps in predicting the associated clinical complications, for instance, interstitial lung disease, myocarditis, and so on, as well as the prognostication, and sometimes to predict the response to treatment. This can be helpful. And myositis antibodies can broadly be classified into myositis-specific antibodies and myositis-associated antibodies. Talking about the MSA, or the myositis-specific antibodies, markers for identifying homogeneous subsets of myositis and genetic factors contributing to the disease. MSA antibody have always been very specific to the clinical syndromes or disease, and hence they are not found in other forms of autoimmune connective tissue disorders, and they give a diagnostic specificity exceeding 90%. And another feature is a single disease entity or a patient does not share 2 MSA antibodies or specific antibodies together. They target cytoplasmic, nuclear, or ribonuclear protein involved in gene transcription, protein synthesis, and innate viral immune response. And this is a table that shows all the clinically relevant myositis-specific antibodies identified and described so far, and under which we have our famous anti-synthetase antibodies, which are also known as anti-ARS antibody. There are 8 antibodies contributing to the anti-synthetase antibody syndrome, and Jo1 being the most widely known, well-known, and most common antibody. And then you have the anti-M antibody, which gives rise to the classic dermatomyositis picture. And anti-TIF1 and NXP are notorious to be associated with malignancies. And MDA is the clinical entity that gives rise to a myopathic dermatomyositis, where myositis is absent in the clinical, although the clinical manifestations are of dermatomyositis. And then the SRP and HMG-CoA reductase antibodies are associated with rapidly progressing necrotizing myopathies. I'll be discussing each of these antibodies and their clinical relevant syndromes separately in future slides. But before that, we'll take a look at the discovery of these myositis-specific antibodies. They were first described in 1975. MI2 was the first to be described, followed by Jo1. Up until 1991, most of the antibodies that were described are related to the anti-synthetase antibody syndrome. That's why it's very popular among us. But if you take a look at this chart, since 2005, there have been a lot of novel antibodies which are clinically very specific to the disease and giving a lot of information about the disease subsets of inflammatory myositis have been discovered and still adding to this, and this process is ongoing actually. Talking about the other subset of the myositis antibody is the myositis associated antibody, or MAA antibodies. And they're mostly found in overlap syndromes where myositis is just a single feature which is overlapping with other features of autoimmune connective tissue disorders, such as scleroderma or lupus. Even though they're present in up to 50%, they're not disease specific, unlike myositis-specific antibodies. This can be present even in the absence of myositis in other forms of autoimmune connective tissue disorders as well, and even among normal population without any clinical disease of connective tissue diseases. And sometimes, unlike MSA, more than two myositis-associated antibodies can coexist together. And again, going back to myositis-specific antibodies, and we'll take a look at their clinical implications or the associated clinical syndromes. And the commonest being, and most popular one being the anti-synthetase antibody syndrome, which is also known as anti-RSA antibody syndrome. And the characteristic feature immunologically here is the presence of anti-RSA antibody, which are directed against the amino acyl tRNA synthetase. And as I mentioned earlier, 8 such antibodies have so far been described. And we all know that the clinical features of the anti-synthetase is myositis, arthritis, the rash with mechanic hands, Raynaud's, and fever. But the ILD is the determinant factor of the disease prognosis or the disease severity. And talking about the anti-synthetase antibodies or anti-ARS antibodies, they're cytoplasmic enzymes that catalyze the binding of each amino acid to its cognate tRNA during protein synthesis. As I mentioned, 8 tRNA syntheses have been described. An antibody to anti-synthetase antibody occur in 25 to 35% of patients with autoimmune myositis or inflammatory myositis. And out of which the commonest being the Jo1 antibody, which occur in more than 75% of the all patients with anti-synthetase antibody are Jo1 positive, and that account for 15% of dermatomyositis and up to 30% of the patients without skin manifestation showing polymyositis. And here in this anti-Jo1 antibody syndrome or anti-Jo1 anti-synthetase syndrome, the characteristic feature is what textbook describe about anti-synthetase antibody, the myositis being the commonest presentation, which is associated with ILD, usually NSIP form, and seronegative arthritis, Raynaud's, rash, and fever. And if you have anti-Jo1 positive anti-synthetase antibody, that actually is a good predictor of a good prognosis. As well as the RIM trial or the rituximab in myositis trial suggests that presence of a Jo1 antibody indicates good response to rituximab as well as steroid. So if you have Jo1, which is the commonest anti-synthetase antibody, it's a predictor of good outcome and good response to treatment. And then let's talk about the anti-synthetase antibody where Jo1 is absent, where you see the other forms of anti-synthetase antibodies. The commonest being PL7 and PL12, which are found in less than 5%. The other antibodies are quite rather rare. The Ks, OJ, EJ, ZO, and so on, they are only found in less than 2% of the patients with inflammatory myositis. What is important clinically is they're characteristically associated with quite rapidly progressing and severe form of interstitial lung disease. So if you have anti-synthetase antibody other than Jo1, that indicates poor prognosis. Another clinical feature is if you're dealing with non-Jo1 anti-synthetase antibody syndrome, the sole presentation could be interstitial lung disease without other manifestations of anti-synthetase antibody. So they could present to the respiratory department with rapidly progressing interstitial lung disease. And if you don't opt for the antibody myositis antibody profile, you may overlook the underlying association with antisynthetase syndrome. And then after that, we'll talk about the clinical subsets of syndromes that manifest as adult onset dermatomyositis. So what are the other antibodies that present as adult onset dermatomyositis, where you see the typical skin involvement with Gottron papules and Scholl signs and so on, in addition to myositis? There are 5 such antibodies have been described so far: the anti-MI2, MDA5, SAE, TIF1 gamma, and NXP2 antibody. And we'll discuss one by one. The anti-MI2 antibody is associated with classic dermatomyositis, which is seen in 10 to 15% of the patients with dermatomyositis. And the skin manifestations are classic with Scholl sign and Gottron papules. And it's usually, it's not associated with malignancy or interstitial lung disease. Hence, it carries a good prognosis. And usually, according to a RIM trial, it's a predictor of good response to rituximab. So if you see a patient with dermatomyositis and anti-MI2 antibody positivity, you don't have to worry too much about screening them for malignancy or interstitial lung disease, and rituximab could be an early option. And then the characteristic antibody that is associated with a myopathic dermatomyositis, where the skin manifestations become the predominant clinical feature, and myositis is either mild or absent, which is known as a myopathic dermatomyositis, associated with MDA5 antibody, which is commonly seen, which is an antibody commonly seen among Asians compared to white. And this antibody could also be associated with rapidly progressive ILD in 50% of the patients. And muscle enzymes and muscle MRI can be abnormal, even though you could not clinically appreciate any muscle involvement. So it is important, if you see the dermatological features of a DM or the dermatomyositis, to do the aldolase and muscle MRI to identify the subclinical form of myositis. So, and then the final antibody related to the dermatomyositis is anti-SAE antibody, which is more common among Europeans, but among Asian, it gives rather severe disease involving the bulbar muscles and lung, as opposed to white. And however, the promising thing is it's not associated with malignancy, and even the lung disease has a good prognosis and response to treatment. And that brings us to the dermatomyositis clinical subsets or syndromes associated with antibodies giving rise, which are cancer associated or malignancy associated dermatomyositis disease entity. There are 2 culprits, anti-TIF1 gamma antibody and anti-NXP2 antibody. Talking about the anti-TIF1 antibody, which is a quite common antibody among dermatomyositis patients, accounting for 20 to 30% of the patients. And this is seen in both adult form and in juvenile form in children. However, it is the adults, in adults, this is associated with malignancies, and you have to worry about. And usually anti-TIF1 gamma antibody present as very aggressive skin involvement, and muscle disease here is minimal or mild. And usually the CPK level is normal. And if you do an aldolase, it's usually elevated. So it is very important that if you suspect myositis in a patient with inflammatory myositis, to bear in your mind that there are disease entities or clinical syndromes where CPK level could be normal. So you have to do other muscle enzymes such as aldolase, or to opt for an MRI to see MRI changes. And talking about the TIF1 gamma, why it's associated with malignancy is because it's implicated in the regulation of our famous P53 oncogene suppressor. Hence, it's associated with solid malignancies, adenocarcinomas of the lung, colon, and stomach in adult patient. So the take-home message is, if you see an anti-TIF1 gamma antibody in a patient with dermatomyositis, and if the patient is an adult, cancer surveillance is a must. But if the patient is in children, you don't have to worry too much, because in children, it's not known to be associated with malignancies. And the sensitivity of diagnosing cancer-associated DM among adults is quite high, actually, and it's 75% with a specificity of 90%. And then the other cancer-associated antibody is the anti-NXP2 antibody, which is seen in 20 to 17% of the patients with dermatomyositis. And this antibody is seen in the juvenile form as well, although it's not associated with malignancy. And if you see an elderly patient, particularly a male with dermatomyositis positive for NXP2, again, it warrants cancer surveillance. Again, the presentation is characteristics, rapidly progressing skin lesions with fingertip ulceration, but the very peculiar feature associated with NXP2, a noteworthy thing, is the subcutaneous calcification. So if you see a subcutaneous calcification in an adult male, think about cancer association. And again, in both these two TIF1 gamma and NXP2 antibody associated with cancer, your muscle disease is either mild or absent, where the CPK is usually normal. But if you do MRI in both instances, you can see abnormalities. And with that, we'll discuss about the clinical syndromes associated with immune-mediated necrotizing myositis. It is a disease entity where you see a very rapidly progressing muscle weakness associated with very severe myalgia, unlike other forms of DMs and PMs. Here, the myalgia is a predominant feature. And if you do CK, you see sky-high levels because of the myonecrosis in histology. And there are two culprits for this: the anti-HMG-CoA reductase antibody and anti-SRP antibody. And in anti-HMG-CoA reductase antibody, as we all know, it's an HMG-CoA reductase is a key enzyme of cholesterol biosynthesis and specifically inhibited by the statins. HMG-CoA reductase antibodies are present in 3 to 8% of the adult populations with myositis. However, if you dig into the history, only 80% of them reveal there's a significant statin exposure for more than 1 year. The rest of the 20, if you couldn't elicit a history of a prolonged statin therapy for nearly at least a year, you always have to screen them for malignancy, because HMG-CoA reductase antibody positive myositis can be associated with malignancy. There are a few Japanese studies and case reports where they could not identify a statin exposure, neither there was any malignancy association. So then they put the blame on the ingestion of red yeast rice and exposure to certain mushrooms, or ingestion of mushrooms such as oyster and shiitake, causing HMG-CoA reductase antibody positive necrotizing myositis. And clinically, as I mentioned you earlier, it's a very rapidly progressing myonecrosis with myalgia, and posterior thigh muscles are the first to get involved here. And usually it's not associated with lung disease or dermatomyositis features or skin manifestation. So you get isolated myositis in myonecrosis. Unfortunately, the prognosis is guarded and it could be refractory to treatment. Hence, it warrants early consideration of IVIG and rituximab as second or third line if you suspect a necrotizing myositis. And then the SRP antibodies, they are found in 4 to 8% of the patients with myositis. And I would say the SRP is the most virulent antibody out of all which we've discussed today. It causes very rapidly progressing severe myositis, and that is associated with myocarditis or cardiac involvement, plus bulbar involvement resulting dysphagia. There's no association with interstitial lung disease or rash. And usually, if you see a SRP antibody, you have to keep in mind that the response to your conventional treatment is not promising. And the 5-year survival here is 30%. With that, now what we've discussed so far are the myositis-specific antibodies, which define certain clinical syndromes or subsets. And then with that, we'll take a look at the myositis-associated antibodies and its relevant clinical syndromes. In myositis-associated antibodies, as I discussed earlier, are seen in overlap syndromes, where 2 or 3 autoimmune connective tissue disorders are overlapping with each other, and myositis is one such component. And there are 4 MAA antibodies have so far been identified as clinically important. They are the anti-Rho antibody, which is a famous antibody you see in Sjogren's disease. An anti-PMSCL antibody gives rise to a clinical entity called scleromyositis, which I'll be talking to you, and KU antibody, and our famous U1-RNP antibody, which is the antibody seen in mixed connective tissue disorders. And a few words about the scleromyositis. Scleromyositis is the commonest scleroderma overlap syndrome, where you see the features of scleroderma overlapping with the inflammatory myositis. Here, one characteristic clinical feature is arms are more weaker than upper limbs are more weaker than hip flexors or the lower limb. And other classical features of scleroderma, such as Raynaud's, ILD, arthritis, are there. The anti-KU antibodies also gives rise to a syndrome similar to scleromyositis. And both these overlap syndromes, where myositis overlap with scleroderma, are essentially a limited cutaneous variant rather than diffuse disease, what you see. And there are the digital ulcers, and Raynaud's are not very common, but the myositis, arthritis, and interstitial lung disease is quite common compared to your classic anticentromere antibody positive limited scleroderma. And then a few words about the MCTD, or the mixed connective tissue disorder, which is characterized by the presence of URNP in very high titers. And the current defining criteria suggests to look for a titer above 1 in 1600. And this disease entity, the MCTD, is characterized by the overlap features of scleroderma, lupus, inflammatory myopathy, and even arthritis. The clinical criteria are the Raynaud's synovitis, swollen hands, myositis, and acrosclerosis. And another hallmark in the clinical disease is the absence of severe renal disease and CNS involvement. And that, of course, brings us to the conclusion. At the end of this lecture, we've discussed the myositis-specific antibodies and myositis-associated antibodies. And let me share with you one of my local experience here in one of the district general hospital in the periphery. It was a 47-year-old female who presented with 3 weeks history of prodromal symptoms and fever, including myalgia. But since admission, she rapidly developed severe neck swelling and dysphagia. Hence, she was transferred to the ENT ward. Initially, it was thought due to the infective in origin. However, the investigation on admission showed a very high transaminitis with AST more than ALT, and the inflammatory markers were also quite high. She was extensively investigated for a bacterial infections with cultures, swabs, and viral etiologies have also been ruled out. And the CT showed retropharyngeal exudate extending from skull base to the upper thorax. And we didn't have MRI in monoragal, but the CT showed quite diffuse swelling and inflammation of the strap muscles of the neck. And at that point, the ENT surgeons were initially thought of infective etiology and started her on a broad spectrum antibiotic, despite which she deteriorated rapidly with new development of severe myalgia and muscle weakness. And bulbar weakness aggravates, requiring the NG feeding. However, reassuringly, her echocardiogram was normal and she didn't have any myocardial involvement or respiratory muscle involvement. And at that point, they took input from rheumatology, and the CPK was suggested, and to see the level was 18,000. While thinking of the other infective etiologies, we made the tentative diagnosis of immune mediated inflammatory myositis as well, while continuing the antibiotic therapy. We started her on methylprednisolone 1 gram for 3 days. In parallel line, we arranged a muscle biopsy as well, which subsequently came as necrotic fibers with regenerating fibers and myophagocytosis. So the muscle biopsy is in favor of necrotizing myositis, hence, and because of the very rapidly progressive nature and bulbar involvement, we thought of straight ahead starting an IVIG over 5 days, to which she had a promising response, and she was put on the MMF as a maintenance therapy and a tapering of oral steroid. And the repeat CT shows some resolution, and CPK came down to 3000s. However, unfortunately, after 4 months, she again presented with a similar symptom, but this time more severe, particularly the bulbar involvement, and the CPK levels was 20,000s. And even this time, we couldn't appreciate any myocardial involvement. And at this point, we thought of doing an myositis antibody profile, and she could afford it. And here the anti-SRP antibody was positive. As I mentioned to you earlier, the SRP was the most virulent, resulting very resistant myonecrosis with a poor prognosis and a poor response to treatment. If we did this earlier, we would have predicted this outcome. Anyway, we did it in retrospect. At that point, we initially started IVIG again for 2 days and started rituximab 1 gram for 2 weeks apart, to which there was a promising response. And now she's on maintenance therapy with MTX and azathioprine and 6-monthly rituximab with physiotherapy. But mind you that SRP antibody usually associated with very poor prognosis. And what happens is they achieve remissions, but intermittently they get flare-ups, and subsequently it affects their myocardium and other sensitive muscles as well. So that is all about the talk today. And that one of the questions people ask is, now you discuss a lot of antibodies, are they available to us? What is the experience in Sri Lanka? Are they useful for us in Sri Lanka? Yes, they are available. They are available in selected laboratories in the private sector, and they have to send the sample to India, and it takes couple of weeks to get the results. But still, I must say that myositis autoantibody profile is more informative to make a diagnosis and to predict the outcome, to predict your management and to plan management. And cost-wise, the cost is definitely a constraint, yet it is cost-effective than a muscle MRI and a muscle biopsy in the private sector. So these antibodies are available to us, and in most of the developed world and specialized centers, where even I worked in UK, muscle biopsy is now obsolete. Rather than opting for a biopsy as a first line, they go for muscle MRI and these antibodies. And if antibodies are positive, you categorize into each of the syndromes which we discussed today. and then start treatment. Muscle biopsy is only indicated if you're dealing with an antibody negative patient, particularly the specific antibody negative patient, to make the diagnosis and to rule out the differentials. So this is the summary, this single chart, which was published in Rheumatology Journal, summarizes our talk today. I think this is important for all our postgraduate trainees if they're preparing for their postgraduate exams in rheumatology and neurology. All right, thank you very much and for your patience, and sorry for the interruption. And I would like to thank once again both the colleges for giving me this opportunity.
Thank you.
Thank you. Yeah. Continue.
Yeah, thank you, Danushka, for the lovely presentation, and I appreciate you taking up this challenging topic. There is one question by some anonymous person. In amyopathic or hypomyopathic dermatomyositis with rapidly progressive interstitial lung disease, what is or are the markers for doing full set of? Can you hear me?
I'm afraid, sir, it's getting interrupted. Yeah. So what is the question? In amyotrophic,
amyopathic or hypomyopathic dermatomyositis.
Yes.
Rapidly progressive ILD. What are the best markers to perform, as doing full set of the panel will be financially troublesome?
Unfortunately, at the now in centers where I work, and even in Sri Lanka, they do the full panel. You can't, as far as I know, if I'm not mistaken, you always request the full panel because that is what they do and that's what they charge for. But then definitely, if an amyopathic myositis, if you're dealing with it, it's the amyopathic one is the MDA antibody that is associated with the amyopathic thing with lung disease. So there's only one disease, one antibody so far being described as amyopathic myositis. That is the, let me get the slide back, MDA antibody. So this is the MDA5 antibody, is the only antibody currently known, because this is an ever developing field. But at the moment, the clinical scenario that the person who asked the question tallies with the MDA5 antibody to give him an answer. But I really don't know whether you could separately request this. In UK, you could. Even here from India, I think you need the whole panel. All right, sir. I hope it gives you the answer.
Thank you. Thank you, Dr. Kuldisanayake.
Thank you. Thank you very much, Dr. Danushka Karunaratne. Danushka is a consultant in rheumatology and medical rehabilitation working at Teaching Hospital Kurunegala, and we appreciate your contribution to the College of Physicians in the form of this college lecture. And have a good day, ladies and gentlemen who have been in the audience.